The next speaker that I have the pleasure to introduce is Dr. Andrea Gershon. One of the things that, again, is really great about the foundation is the ability to support people through grants, which enable them to take certain paths within their career and enable us to allow people to grow within their research. But I think as important to that is the ability to support people themselves, so that there's the ability that we can reach out and we can help people, specifically in the area of knowledge translation, to really dive deep into the work that they're doing so that they can have an opportunity of disseminating that work to others. And that brings me to the Graham Farquharson Knowledge Translation Fellowship, of which Dr. Gershon was the recipient for 2013. She's an assistant professor at the University of Toronto and the research director in the Division of Respiratory at Sunnybrook Health Science Center, and she's also a scientist at the Sunnybrook Research Institute and the respiratory program lead at ISIS, the Institute for Clinical Evaluative Sciences. So this fellowship has allowed Dr. Gershon to conduct translational research to develop methods to measure the quality of care for people with chronic obstructive pulmonary disease. So this is the first step in a program designed to improve the care and health for thousands of people with COPD living in Ontario and external to Ontario. And Dr. Gershon has many publications in high-impact journals such as Lancet and the Annals of Internal Medicine, and I'd like you to welcome her, and we look forward to her presentation. I'm told that Dr. Gershon and Dr. Petrov have a link, actually, that so maybe she can explain that a bit further.
Yes, it was very exciting to see Elaine again. We went to medical school together, so it was very exciting. Great. So thank you very much for having me here today and for the opportunity to talk about some of my research. I am the 2013 Graham Farquharson Knowledge Translation Fellow, and it has been an amazing honor. I've been able to do so much, and I'm very excited about it. I'm glad, I'm excited to share it with you. The sentence is study, but the work that I've been able to do in this last more than a year has been amazing. And I say the work that I've been able to do because it's not just been one study, it's been many studies. And most of the ones, some published, some not published, that I'm going to describe here are because I've had this fellowship and I've had the time and the freedom to be able to work on these things. And I haven't met Mr. Farquharson yet, but I hope to soon, and it is really an honor to have a fellowship in his name. And I read about him and real stimulation to medical research. I think this is a great, great thing and that you're on the right track. And again, thank you very much. But today I'm going to talk about COPD. So just in general, I'm going to give some background on COPD. I'm going to talk about COPD quality of care, which is where my research focuses on. I'm going to be talking about the main project my main translational research project that I'm doing as a translational research fellow, which is developing COPD quality indicators. And then I'm going to show you a bit of where those quality indicators have gone so far and where we're planning for them to go in the future, and then I'll just summarize things, and I'm happy to take questions at any time. So I don't have to tell you, but COPD is an incurable, progressive, but manageable chronic respiratory disease that's characterized by irreversible blockage of the airways of the lungs. In Canada, it's usually due to smoking, but other countries it's due to other things, and there's biomass fuel exposure is a big one, and now there's a hypothesis that actually asthma, chronic asthma, especially if it's not treated properly, causes COPD. Of course, as you know, it's historically known as emphysema or chronic bronchitis. So this is why I show my patients. I say, think of your lungs as being a bunch of tubes, one big tube that divides in other tubes. It's, obviously, this is a disease of the very, very small tubes, the bronchioles and the terminal bronchioles and alveoli. And people who have COPD come to me with shortness of breath, cough, fatigue, weight loss. But it's really an issue that they can't do the things they want to do. They can't climb stairs, they can't walk, they can't buy groceries, they can't do their activities of daily living when it gets very bad. This is a bad, bad disease. And here's some people who have COPD, so some pictures. So, I mean, there's a traditional if you remember in medical school, and this is a very old picture, which is why I think you can get away with just blocking off the eyes, not anything else anymore. You have the classic blue bloater, and then you have the classic pink puffer, if you recall, that we learned about. Chronic bronchitis and emphysema, but now, of course, we all call them COPD. You have your celebrities, and I love this one here. Like, I got the cigarette, this is great. Who've had COPD. But many people don't know that COPD is becoming more common in young women. And so now we have supermodels and musicians who are coming out with COPD, and that's following the trends of smoking being more common in young women. And COPD is increasing. COPD prevalence is going up in Ontario and much of the rest of the world. So this is a study we did publish in 2010 that showed the prevalence rate of COPD, and it's increasing in women a little more than men. Seems to be leveling off here, but actually this is to 2007. We have 2011 data that shows that it is still going up. And this is a study we had published looking at the lifetime risk of developing COPD. And basically what we showed was that about 1 in 4 adults over age 40 will be diagnosed by a physician with COPD at some time during their lifetime. So if you show here, look at the blue line here, we see COPD, lifetime risk obviously goes up with age. It's around 27%. It follows just short of asthma and diabetes, but is higher than congestive heart failure and prostate cancer in men, and over here in breast cancer in women. So this is a serious disease, and it's a deadly disease too. COPD is the 4th leading cause of death in Canada. It's the 3rd leading cause of death in the US and the rest of the world. And I think the reason why we're lagging behind in Canada is because our statistics are a little bit old. And when they update them, we'll find that COPD has also surpassed cerebrovascular disease as a cause of death. And COPD is a leading cause of hospitalization. One of the top causes of hospitalization in Canada. Here we have COPD being compared to angina, asthma, heart failure, diabetes. It's also the #1 cause of hospital readmissions and hospital readmissions, which is what this top part here. And then finally, as if it wasn't already obvious with the hospitalizations, COPD places a huge burden on the healthcare system. So this is a study that we've done. Again, I'm putting in the plugs here, a study made possible by this finished with this fellowship. And what we did in this study is we looked at all the hospitalizations in Ontario. So this borrows all the hospitalizations in Ontario, and this is the number of hospitalizations in Ontario made by people with COPD. So 25% of hospitalizations in Ontario are made by people with COPD. And this speaks, and obviously those aren't all hospitalizations for COPD. This speaks to the fact that COPD comes with a lot of comorbidities that COPD either accompanies or is oftentimes responsible for. So huge burden. Same with emergency department visits, about 1/4 of emergency department visits in Ontario made by people with COPD. We have ambulatory care visits. 1/3 of people in long-term care have COPD. So again, huge burden on the healthcare system. I think you'll agree with me that quality COPD care is critical. Is crucial to improve people's health and to reduce healthcare costs. And I'm going to be talking a lot about quality of care, so I'll just define it here. Quality care is care that is safe, effective, patient-centered, timely, efficient, and equitable. Of course, there's different definitions, but usually they all hit on these points here. And I'll just digress for a second, because how do we get to this point? How do we have this disease that's so prevalent and so deadly, and I guess I'm going to argue that not much has been done about it so far. I think the challenge for people working with COPD and challenge for people with COPD and physicians is that the connection to tobacco has been a major impediment. And there's an often unspoken belief that COPD sufferers are authors of their own misfortune. Said by a journalist, has much better language than I do. COPD does not have a high profile, it's forgotten and overlooked, and the result is an illness that places tremendous burden not only on the healthcare system, but on individuals and their families. I personally believe that this is a huge problem and something that we need to work on, and I think the situation is getting better, and I think that PSI recognizing this is been very important as well. So from adversity comes opportunity, so I call it the COPD opportunity, because I believe there are so many simple things that we can do that will improve the health of people with COPD and decrease strain on the healthcare system. Simple, easy, relatively inexpensive, just because there's so little being done out there right now. And one of them is getting good quality of care. So quality of care is crucial, I mentioned, to improve people's health and improve their healthcare costs. Now, to approach this problem, I adopted the translational research knowledge to actions cycle. So this CHR promotes this, but you can see different versions of this in many different areas in different parts of the world. So very briefly, this is a cycle to put knowledge into action, in this case to improve quality of COPD care. So you start here at the bottom, you identify a problem, you identify the knowledge you're going to use to fix that problem, you adapt it to local context, so in this case to Ontario, you look for barriers, why is that knowledge not being used the way it should be, in this case knowledge of quality COPD care, you use what you gain here to select or create interventions or strategies to improve, in this case, quality of COPD care. You monitor it, you evaluate those strategies, those interventions to see if they work. And then it doesn't end there because you have to sustain that knowledge use. And by that time, you've probably found some problems with those strategies. You have to identify the problem, you basically start all over again. It's in a continuous improvement cycle. So this is the model that I have adopted with all my research. So, but I'm still right here at the beginning, sorry. We're still right here at the beginning with COPD quality of care. So identify the problem. So I'm presuming that there's a problem, but what is the current quality of COPD care? And the answer is basically we don't know because we haven't measured it, because it just hasn't been a high priority for a lot of governments or granting agencies, or definitely a priority for physicians, but they don't necessarily have the resources to do this, right? So quality of COPD and care in Canada is not very well characterized. And I kid you not, I'm going to quote you two old studies, and that's basically all we have right now. The situation is getting better, and some studies look at several different diseases at one time, but in ambulatory care, large gaps in care have been documented for people with COPD taking care of volunteer physicians. So basically they go out in the community, they ask for volunteers, and they measure how well their COPD is taken care of. And in terms of hospital care in Canada, there's one study that showed that 84 of individuals discharged from one hospital, Sunnybrook, which happened to be where I am. I wasn't there when they did the study, but 84% of individuals have at least one important gap in their care, and that this gap, where the people that had the gaps in their care were more likely to have adverse events and longer hospital stays. So this is the study, the CAGE study, which shows practice management and the management of chronic obstructive pulmonary disease. And I'll give you an idea. So when I talk about a gap, and when they went to these volunteer physicians, and I don't know why you'd volunteer unless you thought you were doing a good job to begin with. So I like to propose that maybe the situation is a little bit worse than this. When they looked at people with COPD to see if they're on optimal pharmacological treatment and the medications they should be, they found that about, sorry, it's kind of summarized in all groups here, that about 1/3, 32 to 39% were getting the medications that they should be, which means that 70% or 60 to 70% are not getting the medications that they really should be getting according to guidelines. And also, if you recall, spirometry is how we diagnose COPD. You need to do pulmonary function testing, and we find that 48 to 59% of people with COPD in these physicians' offices are getting spirometry. It should be 100%. Why are the other patients not being diagnosed properly? These are some of the things that we need to work on. And again, I won't go into a lot of detail, but this is the study in CMAJ showing gaps. Again, frequency of gaps, 78%, 64%, 44%. So we have room for improvement. So back to our knowledge to action cycle, we need some way to identify the problem. To identify the problem of quality care, you need to be able to measure it. You need to be able to measure how well people are taking care of people with COPD. And this is a very common saying, if you can't measure it, you can't manage it. You can't manage it, you can't improve it. Measures allow physicians, hospitals, healthcare organizations to identify and prioritize gaps in care, design strategies to address them, like I mentioned as part of that cycle, track improvement or lack of improvement, so evaluate them. So quality indicators are just measures. They're measures used to monitor, assess, and improve the quality of care of patients. They include outcomes of clinical care, like hospitalization, whether a patient is hospitalized or dies, processes of care, so when a physician prescribes a medication, structures of care, so qualified personnel, organizational structure maybe of a hospital, And what makes these measures, these factors unique is that they're associated with such a strong benefit that failure to address them reduces the likelihood of good patient outcomes. So once we have these measures, we can measure quality of care. Now, quality indicators are huge right now. Everybody's into quality indicators. They're endorsed by the World Health Organization, the OECD, everywhere across the world. Even our own Canadian Institutes of Health Research promotes quality indicators. And there's been tremendous energy spent developing, collecting quality indicator data on physicians and healthcare system performance. And this has resulted in improved quality care in hospital care, cardiac care, primary care, patient safety. It's been great. It's been great, but few quality indicators developed and very little work done in COPD. So again, tremendous opportunity. Now the quality indicators for COPD that we have been very rudimentary. I won't go into detail now, but for any of these things, I'm kind of going quickly, but I'm happy to talk about it more if people are interested. They're very rudimentary, missing most aspects of care, and many have not been proven to be associated with improved quality care. So our objective was to develop a comprehensive set of quality indicators for COPD care. And the approach we decided to take was the gold standard approach, the way that you go about developing quality indicators, the top level of evidence, if you will, which is called the modified Rand appropriate method. It consists of a systematic review of the evidence, because you want to make sure your quality indicators are evidence-based. And then it has a Delphi expert panel. So basically you get together. There's argument you can't have too small a panel, you can't have too big, because everybody has to be able to talk. You get together everybody who takes care or has an interest in people with COPD, physicians, internists, respirologists, researchers, health systems administrators, other representative stakeholder organizations. Get everybody together. There's like a very set protocol where you have 3 rounds of ratings and discussions in between it, where we talk about what the quality indicators as well. And the purpose of the panel is to take the evidence, interpret it, contextualize it, and then basically turn it into quality indicators. And also very important is to ensure these quality indicators are relevant to Ontario, to where we live, because you can make quality indicators up and they may not mean anything to anybody, so you have to make sure it's relevant. So we're doing this. We're finishing the systematic review, and we're starting to put together a Delphi panel. But because that's not so interesting to tell you about, I don't think you want to hear me tell me about systematic review. I thought I would move on to talk about how quality indicators are used and how we hope that our quality how I say we hope, but they've already started being used, and I'll show you in a minute. So quality indicators are used to inform and evaluate strategies to improve quality care. So you've measured the problem, you can use it to find out what the gaps are, and then you can develop the strategies and interventions to fill those gaps. And so you may have heard things like targeted disease management programs that are designed to fill certain gaps, paying for performance, perhaps you've heard, public reporting, so you try and shame people into doing good quality care. And then, more behind the scenes, you might use quality indicators to establish standards for healthcare facility accreditation. So a hospital can't get their accreditation unless they're doing a few things. That's based on they're filling the gaps that they've been shown to have. So how are our quality indicators being used? Well, I've already told you we're still developing them. So that's a problem. We don't have them yet. But at the same time, there's a lot of interest in the area. There ends up being some quality indicators that are just kind of obvious, like you got to diagnose a disease before you can treat it. So we've put together a preliminary list, and we've started working with that. So if you remember, our first step was identify the problem. The next step is to identify, we come along here, when we identify the problem, we're also kind of identifying, because we're doing the evidence search, the knowledge that we need to apply it. We're up here now, so assessing barriers to knowledge use. So these are 3 studies that we've done that we've actually started using our quality indicators in. The first one is the one that part of it I showed you at the beginning. So quantifying health services used for chronic obstructive pulmonary disease. In this case, we use quality indicators that are outcomes indicators. And we've shown that compared to people without COPD, people with COPD make 1.63 times more hospitalizations. So they have a relative rate of health service use of 1.63, adjusting for other factors. So 63% more hospitalizations, 85% more emergency department visits, about 50% ambulatory care visits. So again, we're identifying the problem, we're showing where some of the issues lie. This is another study. So again, we're not finished doing our quality indicators, but is like this strong leaning and what other people have done in the past. You need to diagnose a disease. You should do the pulmonary function test. Pulmonary function tests are used to diagnose COPD. So how can you really know if somebody has COPD if you're not doing the proper test? So we looked at patient and physician factors associated with pulmonary function testing in COPD. So the first, and this has been published. The first thing we showed was that only about 33% of people diagnosed with COPD in Ontario receive pulmonary function testing. And again, this is small. It's a forest plot that shows people of different age, gender, and different comorbidities, long-term care, whether they're more or less likely to receive pulmonary function tests. So we're starting to look for that, looking for the gaps. Where are the gaps to knowledge? It seems to be some issue. Again, I'm sorry it's small. I'm happy to give you more of this, but I just wanted to illustrate a little bit of what we're doing. Older people and younger people diagnosed with COPD don't seem to get pulmonary function tests. Women seem to be less likely to get it than men. If you're in long-term care, you probably haven't gotten pulmonary function test, and this is controlling for other issues like dementia and the other things that might impair your ability to do the tests. So again, we're using the indicators to start to identify these gaps, and then we'll think of the strategies to fill them. We've also done, this is another study we have in progress, looking at disparity in access to COPD medications. So again, we're looking at whether people are getting the medications that they should be. And what we found was, we looked at people over the age of 65, so they're covered by Ontario drug benefits. We looked at disparity in socioeconomic status. Actually, not so bad. Like people of lower socioeconomic status seem to be getting the medications. But for some reason, older women don't seem to be getting these medications as much as the older men or their younger women counterparts. So again, we're identifying something going on there. There's some sort of barrier to knowledge use, and now we have the opportunity to develop something to fill that in. But we're actually not the only people who are using our quality indicators. So these development of quality indicators have generated a lot of excitement and interest, and people are like, when are you going to have them done? When are you going to have them done? So we had to kind of like we want people to be using something, and they have nothing. They're just making up off the top of their head right now. So we created a preliminary list, and we started to give this out in draft form to some people. So the Ontario Ministry of Health is very interested in this. Kingston General Hospital has started using this for some of their COPD program. This is a Pristine, Pan-Canadian Respiratory Standards Initiative for Electronic Health Records. They're developing tools for EMRs across Canada, and they want to use our quality indicators for that. The Ontario Lung Association has started using it in their teaching, and I've had people, many family doctors who have contacted me and be like, do you have any quality indicators? We want to start measuring this. We want to make our practices better. And I've given this as these are preliminary. We're going to come up with better ones, but at least you have something to work with right now. So this is, you've heard of quality-based procedures, quality-based funding that the Ontario government's now doing. So one of the first quality-based procedures, they're now going to pay hospitals for quality. It's been pretty big. Our quality indicators are in there. So they're going to be using our quality indicators to measure quality of care. And I'm not sure if other people, if you're familiar with Health Quality Ontario has a new initiative partnering for a common quality agenda, where they're looking at certain quality indicators over time, and they'll be focusing on these things. They've never had COPD quality indicators before. Don't ask me why. Now they do, and they're using ours. So again, very exciting things happening going on. So our next steps are to finish developing quality indicators. We still have work to do. And then we're going to go out there, basically do more of what we're doing right now, what I've showed you. We're going to measure quality of COPD care. We're going to implement interventions. We always are, as I've shown you, we always have some great partners, Ministry of Health, Health Quality Ontario, other interested groups, family doctors who are really eager to get this done. So we have a lot of partners to help us do that. We're going to monitor the quality indicators. We're going to go right around the circle. We'll evaluate them and sustain the knowledge use. So, in summary, COPD is a pressing health concern. Good quality care is crucial for people with COPD to improve people's health and to relieve strain on the healthcare system. And developing COPD quality indicators is a fundamental first step to improving quality. I'd just like to acknowledge the ton of people who have helped me out, so, including the Physician PSI Incorporated Foundation, CIHR, Public Health Agency of Canada. There's been wonderful support for this. And thank you very much.
Thanks, Andrea. That was an excellent presentation, and it's a great testament to the amount of work that one can take on during the fellowship, and we look forward as that continues over the next while. I'd like to open for questions, and once again, if you could please come up to the microphone. Thank you.
Thanks for a great talk. As the author of these epidemiologic studies, how do you help prevent other people, like policymakers and administrators, from drawing the wrong conclusion from some of your headlines? And by that I mean, I'm sure we understand that you found a lot of associations, but that doesn't necessarily imply a cause and effect. And there are many extreme examples of associations, and so that one would, as a policymaker, be tempted to treat the association or a quality indicator in hopes that it would have an impact on what you really want to get at. And so because it's such an important field, so common, the third highest cause of death, and now we're looking at QPPs and so on, how do you prevent from people taking your data and running with it and sort of saying, well, now I have the conclusion that there's a cause and effect here?
So you hit on a number of really good points. And one of them is the limitations of quality indicators. So I'm showing you that this is the best thing, and I didn't go into limitations because I don't have enough time. But this is really still a developmental science. And there's big issues if you don't adjust for other things that might be causing, like if you're going to use quality indicators to compare the care between one family physician and another, you have to make sure you adjust for comorbidity and age and other characteristics of their patients. And there's always a danger of attributing bad care to the wrong hospital or the wrong land, the wrong area. So we need to do a lot of work. So I believe there's a lot more research in the area. A lot more research that needs to be done in the area. Working with decision makers, government, has been a challenge, and I agree with you 100%. Working on the quality-based procedures with them has been a challenge, and I'm always the naysayer that says, no, you can't do that. So the way I approach it is by trying to work with them carefully and advising them and reminding them about how we're supposed to use the data and what can be done and what can't be done. But in the end, it's a compromise. It really is a compromise, because at the end of the day, they need to get something done, and they have a certain amount of time, and there's a tension, because I want to do it right, and that takes a lot of time. So the compromises are made, but I hope and I feel obliged to be at the table, to be there, to help them, to work with them, to make sure that it's done properly. And I think that a lot of people in the room feel that way, because I know there's a lot of physicians that have volunteered to play that role. Thank you for the question. It's very important.
Well, again, thank you very much for a good talk, and amongst your many achievements, you've mobilized such an impressive number of partners, and that is a really good indicator of success. In follow-up to Andrew Baker's question, I worry about quality indicators being too oriented towards process, and I'm wanting to ask, are you looking at patient outcomes with such measures as quality-adjusted life years, generics, specific, or disability-adjusted life years? Because that's the product we want, and the cost to get there. And what I've noticed about quality programs in hospitals is that becomes feeding the beast a bit about process. So I'd be interested in your comments on that. And again, thanks for your paper.
Thank you. Thank you very much for your comments. And I think that I've been fortunate to kind of step into this area at the right right place and the right time, because there's a will to make this happen. And so that's why I've been able to work with such wonderful partners who have supported this. Sorry, I just said that. Now I just forgot. Sorry?
The process indicators are
right, sorry.
versus outcome.
Yeah, so we are looking at quality indicators, that patient-oriented quality indicators. So we are including quality of life, symptoms, things that are important to patient. I think that's where I'm coming at from my point of view. And luckily, those quality indicators end up being the same ones that keep people out of hospital. But that's a very real concern, and something that we have to maintain awareness of as we do this. Do you want to be on a Delphi panel?
Again, thanks very much for the presentation. Given that COPD is so much associated with tobacco use, are you including as one of your process indicators, and hopefully as an outcome, evidence-based smoking cessation advice and therapies and quit rates as a core quality indicator for prevention on a primary scale?
Completely, absolutely. That's one of our key areas.
So that would be across the health system, not just for respirology, but across primary care settings.
Yeah, actually, our quality indicators are very primary care based, because that's where most COPD is being taken care of by primary care physicians. Thank you for the comment. Thank you very much.
Thank you.